They will make your life hell. Why are you even waking me up for this nonsense? Just... On Reddit, someone asked, what do you wish you were taught more about early on in residency? Anything that you had to learn the hard way that would have made your residency experience a lot easier if someone had just taught you about it. So today we're going to react to this thread. The top comment is that taking breaks and resting for a bit to avoid burnout doesn't mean you're a pansy, and if you're being shamed for it, then there's something wrong with them, not you, and it doesn't make you a bad doctor. And that despite all efforts, patients can still not make it, and it isn't your fault always. How their body responds to the treatment is not something that you can control, so don't beat yourself up for it or cry about it all the time. You have to remember that medicine, it's a marathon, not a sprint, as we like to say. And if you go too intense for too long without taking care of yourself, you will burn out. That's just human psychology, human nature. So it's important to take breaks and understand that operating at 10/10 day in and day out is a recipe for disaster. You will burn out. And not only are you going to be unhappy and you'll feel depressed or burned out or just miserable during residency, but your patients are going to suffer too, because if you're burned out, you're not going to be able to provide the best quality care that you would if you were not burned out. So you owe it to yourself and to your patients. Now, keep in mind, some specialties are going to be bigger offenders of this than others. Neurosurgery, of course, being the notorious worst example, where you are really expected to live and breathe and die neurosurgery. But generally speaking, a surgical specialty is going to be more hardcore in its lifestyle, its culture, its expectations versus a non-surgical specialty. And yeah, patients, bad things are going to happen in the hospital, and it doesn't necessarily mean that it is your fault. Sometimes it is, and sometimes it's not. If you're in medical school or residency, you may have heard or seen some M&M conferences. That's morbidity and mortality conferences. And the point of these is to isolate adverse outcomes, which can sometimes be death or other complications, and how that can relate to systemic errors, judgment errors, etc. Things that you can learn from, actionable things that you can improve so that in the future you don't make those same mistakes. And that's generally one of the residents is presenting at conference at grand rounds to the rest of the residents and attendings in that specialty and going through, what happened in this case, what could have been done differently, and so on. If a patient gets pissed off at you, it doesn't necessarily mean you did anything wrong. Many patients have unrealistic expectations and requests. I used to take it hard when patients got upset with me, but I'm better now about putting things in context. Very important. Some specialties, again, are going to be worse offenders than others. In plastic surgery, especially aesthetics, you're going to find a lot of patients who have very high perfectionistic expectations that are not based in reality, and no matter what you do, you cannot make them happy. But of course, that's going to occur in just about every specialty. The way it manifests in different specialties, the patterns you see are going to be different. In pediatrics, it's not uncommon to find very overbearing tiger parents that have very high expectations and are unhappy when their child doesn't have the ideal dream outcome that they're hoping for. I find it useful that anytime there is negative feedback directed at you, don't reactively approve it or deny it. Instead, approach it with curiosity and inquisitiveness and say, you know what? Is there some truth there or not? Could I have done X, Y, and Z better? Or is this person being unrealistic and just too demanding or just too difficult? And if you're not sure about that yourself, then it helps to speak with co-residents or your attendings, your mentors, to get some more perspective. That you don't have to take maltreatment or abuse from a patient just because you're their doctor. One of my attendings essentially told me that if I wouldn't allow some random person on the street to treat me a certain way, that should be the same standard for patients. Being able to say, it seems like there's a lot of frustration here and I want to help you, but I can't do that if you're disrespecting me or my staff. I'll be back once we're ready to have a more respectful conversation, is a game changer, to be honest. Yes, this is a very common thing you're going to see. It's also not uncommon to see doctors straight up fire patients that are being disrespectful. So this is a nice way of saying it because, hey, this is not cool. This is not going to work. Once you behave yourself, we can work together. Other people will just say, hey, this is not cool. We're done here. Go find another doctor. Obviously, when you're a resident and not the attending physician, you have to do the former more so than the latter and say, hey, you know what? Please behave yourself. Then we'll come back, versus just outright firing them. You're not really in that position to outright fire them at this stage in your training. But it is absolutely the right thing to demand a minimum level of respect and courtesy from your patients. That I shouldn't forget, that is just a job. The realization of seeing people die despite our efforts got me in a dark place at the beginning of my residency. Now I'm just thinking, this is how life works, and death is part of it, and doesn't mean that we did something wrong. I developed a healthy system to avoid getting back to that place, and now I'm doing better. Yeah, definitely echoing similar sentiments from a previous comment. Palliative care and hospice care should be a mandatory rotation for all. Death is such an uncomfortable thing for humans to even approach or think about. I think doing a rotation here is going to give you a lot of perspective as to what the dying process actually is like, what is reasonable, what is not, the pros and cons, because some people want to go out fighting to the very last breath, and that often comes with a compromise to their quality of life, with not necessarily much extension to their life. And other people, normally those that have seen more of the former, they tend to do the route of, you know what, I want to have the best possible quality of life at the end of my life, rather than kicking and screaming and doing chemo and this and that may extend my life by 5, 10, 20%, but my quality of life during those months or years is going to be absolute garbage. So it is a very difficult thing when you think about it for yourself or for your loved ones. But I remember finding a lot of value even in reading these 2 books. It's linked on the Med School Insider's reading list for med students. One is When Breath Becomes Air by the late neurosurgeon Paul Kalanithi, and the second one is Being Mortal by Atul Gawande. You can find those linked below. Yeah, this guy's saying his first rotation in residency was palliative care, which influenced his practice for the better. And this story about this guy's father dying from cancer right as soon as he graduates med school, and the radiologist actually had missed the cancer when it was a 2.5 centimeter mass on a CT scan. And the whole lawsuit, dude, this is like, it's always so tragic when you see this stuff. Preventable errors. And then, insurance companies and the system at large, they don't want to pay out, or they don't want to, you see stuff like this and you get a bit discouraged because you see how much money rules the world. And I guess some nurses had convinced the jury that it was fine for the radiologist to have missed the mass. And anyways, yeah, it looks like a really crappy situation for this guy and his family. All right, this one's kind of funny. I'm in IM, so take that how you may, but I see a lot of interns and especially second years fighting with ED about admissions. ED's job is to admit, and we have to accept. Yes, you should push back on inappropriate admissions, but 9.9 out of 10 times it's correct admission. But for some reason, we love pushing back for the sake of pushing back. Like, focus that energy elsewhere. You spending all that energy fighting ultimately leads to nowhere, and trust me, your attending is going to take that admit anyways if it gets escalated. So just try review, go see the patient, write the note, and move on. And someone else is agreeing with that parent commenter. What you'll find in medicine is that things are not always clear-cut. Yeah, you're getting a lot of pushback. I feel bad for ED physicians because they get so much pushback and just shit on by other specialists, because you have to remember, the ED, their job is to know a little bit about a lot of things. They're not the experts in any of these fields. They're the experts at emergency care, right? Stabilizing people. So you got other specialists coming in saying, oh, how dare they not know X, Y, and Z? They should have done this differently, and yada, yada, yada. But that's not their job. To be the expert cardiologist, their job is to stabilize and then refer to the specialist. And yeah, you're going to see that in medicine, things like CYA, cover your ass. It's legally protecting yourself. So you're doing what you need to do in case things go sideways. So then you're legally covered for doing the correct thing, or at least the less risky thing. And you're going to see that CYA does play a role in medical decision making. There are these like tensions between some specialists at times. For example, the ED trying to admit and the internal medicine service not wanting to admit. You're going to see tension there. I think a lot of that tension sometimes comes across as maybe the IM doctors are feeling, hey, this is not appropriate, or hey, stop pushing more work onto us that's not valid. And the ED doctor feels justified saying, no, this is admission worthy, but you get this tension. And this commenter is mentioning that oftentimes that tension is unnecessary. And this is just part of the healthcare system in America, which is so litigious. I remember even in residency, when I was on call, I would get paged by, especially like the younger nurses that maybe weren't as experienced. They would just page you at 3 a.m. over the most insignificant nonsense stuff. You would wake up being like, oh shit, do I need to go to the hospital? Oh no, something that like is so irrelevant that you're like, why are you even waking me up for this nonsense? But I think the reason is that they're not sure what is important and what is not. And they want to cover their own ass. So they're like, hey, I reported everything I needed to report, so don't come at me saying that I didn't report this important finding to the on-call doctor. Comments are getting spicy. Some valid points from both sides, both from the ED and from the IM docs. I do agree it's probably more than 0.1 out of 10 cases where it's a not valid admission, but There is a hierarchy in medicine. Certain people in your program will have benefits that you don't have. You can either make your life worse by making an issue about it, or accept that it's just a job to get where you need to be. I feel kind of mixed on that. The hierarchy in medicine is definitely there and real. I would say that the older, more traditional programs may enforce that more so than newer, more relaxed programs. And while hierarchy has tremendous utility, order of command and all these things, there's also a lot of utility in being able to point out errors and issues from those higher in the chain. So there was this one book I read, I'm forgetting which book it was, about pilot errors and how Korean Airlines had some disastrous crashes because the co-pilot, just based on the culture, wasn't able to speak up to the pilot about some error, some issue that they were seeing. It was more like top down only, not bottom up. And what you'll see in medicine is, for example, in the OR, they very much cultivate the culture of, if you see something that is an issue, speak up. You're going to do all these checks to make sure you're operating on the right side of the body and it's the correct patient and all these things. But the culture is very much moving in the direction that you got to speak up bottom up if you notice something that's off. But this goes beyond just issues like that. And you're going to see some programs will be greater offenders than others with regards to what kind of benefits and privileges the higher ups have over you. Yeah, you're going to have a crappier schedule when you're junior. That's just the way it goes. I don't think that's going to be changing anytime soon. Same thing, like if I was a plastic surgery resident rotating on emergency medicine, yeah, I'm going to get the worst schedule because the people who are actually going into emergency medicine are going to get first dibs and get better schedules during that rotation. But I'm only there for 1 month. They're doing EM for the next however many years. So you have to figure out where the line is. If there is abuse, if there is danger to yourself, issues with safety, you got to speak up. I've talked about stories in the past where I've heard about attendings throwing loaded scalpels at residents. That's obviously a huge issue. And then, of course, vet attending would be subject to some disciplinary action. Still waiting to be taught operating. Fuck me. RIP, watching some of the surgery PGY 4, 5s, and 6s, barely getting to participate in a case is so tragic. Some attendings definitely are more willing to teach than others, but I know I'm going to get flack for this. I think it's more a matter of the competence and the level of confidence that the trainee provides to the attending. So there are two types of attendings, those that really want to teach and those that are like, hey, I want to do things the right way, my way, and get out of my way. You're here just to retract. And working with the former is obviously way more fun and enjoyable, and you're going to learn a lot more. But even with the latter, if they see that you know how to do retraction, which is very simple, but there's a skill set there as well, and then they see you closing, and if you can demonstrate some level of competence and make them feel comfortable giving you stuff to do, then certain attendings, they're going to actually totally leave the room at the end and say, hey, you close. Like, I know you can handle it. I don't want to be doing this work. I want to go home or go work on the note or whatever. They'll leave the room and then you'll be the one closing. So if you're especially later on in residency and you are not getting to be very hands-on in the case, sure, maybe it's one attending who's just notorious for being poor about letting residents have any kind of autonomy in the operating room. But also examine if it's happening with more than just one person. It might be that you're not giving them that level of confidence to let you do those things. If you're not practicing outside of the OR on your various techniques, there's probably something for you to do. Find a social life outside of residency because a lot of your peers are just there to do their work and go home. True, hopefully you find a program where some of your co-residents are going to be your friends and you're going to enjoy spending time with them both inside and outside of the hospital. Oftentimes you're not spending that much time with your co-residents, depending on what year they're at, depending on what rotation you guys are on. It's not like med school where you're spending a lot of time day in and day out with the same people. So you'll be seeing them at conference, of course, and on certain rotations and on certain clinic days or OR days. But I recall there are a couple of residents that I'm still in touch with to this day because they're just cool people. And I like them a lot. And we would hang out outside of the hospital too. There's nothing wrong with doing nothing for a bit. I still struggle with this. It's okay to go home and sit on the couch for a bit without engaging in some kind of self-improvement. Yeah, I think a lot of us are guilty of this. I always found it most jarring after finals week in college or med school, where after you finish your tests and you were studying so intensely for the last week or two, you're now like, wait, what do I do with my time? This feels kind of strange and kind of weird. And in residency, it's even more rare. Those breaks are few and far between because there aren't as many regular exams in residency. You'll be working towards your in-service every year. That's the big thing that you are doing. And your intern year, you'll also be taking step 3. But step 3, you're not studying nearly as hard for compared to step 2, CK as an example. And there'll be some variation here because some rotations are busier than others. But you'll feel it out. I think most people probably don't experience the issue of not engaging in self-improvement. This guy maybe, or gal, maybe a self-improvement aficionado, if you will. Just the natural ebb and flow of each rotation, some being more or less busy than others, will probably keep you in a space where you're balancing. Nurses can wreck your life and will never change, so don't try. Their vision of what's best for the patient may clash with yours. Just be nice to them and give them what they want at first. You can get their best performance out of them once they trust and know you. Okay, agree and disagree with this comment because definitely have a good relationship with the nurses. If you have a bad relationship, they will make your life hell. They will be bothering you about all sorts of things. And I'm glad people told me that as a med student and then also as a resident. That was reinforced. Very important to maintain that relationship. But I don't think that as a doctor, you need to change what you think is best for the patient because of what the nurse is saying necessarily. You should definitely value what the nurses are saying because they're there with the patients more often than you are. And therefore they may see things or have thoughts on things that you may not be seeing yourself. So value that, but ultimately you are the decision maker that needs to prioritize the patient's needs first. Okay, now, always want to keep it real with you guys. So let me find this delicate balance here so I don't get canceled. The personality types on average for doctors and nurses, it's different from my experience. And that's okay. You don't have to, this person saying you don't have to change them, right? And that's fine. One example that comes to mind, my first rotation in surgery as a third year, there's a staff lounge and a physician lounge right outside the OR. And this is where you're working before you go to the OR and you got to put on your mask and all that stuff, right? So where you're waiting between cases and eating if you need to and stuff like that. And in the physician lounge, doctors on computers, silent, getting the work done, then going to their cases or going home. And the staff lounge, way more chaotic, a lot of chit chat, a lot of gossip. I remember sitting there once and there was a conversation at the table next over and it was nurses and techs and whoever else. And, just like gossiping about some drama about like a lunchbox and the lunchbox was moved. And like, it seemed so insignificant to even be talking about, which is fine. I didn't partake in that. I just read my book, realized that those are just not the conversations for me and not the kind of vibe I want. I'm going to just put my head down, get my work done, go to the cases and on to the next. But that being said, a lot of nurses are fantastic. My girlfriend's a nurse, nothing against nurses. Just be aware that the vibe and the way you mesh with different types of personalities based on who you are. You may get along with certain people better than others, and that's okay. You can still be polite and cordial to all people, regardless of how similar or different your personalities are. So if you're going into neurosurgery, you probably have a very different personality type than the average nurse, but that's okay. You still don't have to be a douche. Small one, but I'll add, sit down. When you're just flying by, it's okay to stand for a quick chat, but when seeing a consult or discussing things in the room on rounds, find a place to sit. Patients really appreciate it and perceive that you spent more time and listened more. Plus, you're not towering over them in doctorly judgment. That's a really good point. Bedside manner, the nuances of human communication, the body language of sitting versus standing. Really good point. Pull up the scan, pull up the RAS report, try and find everything they know. Learning to read your own images will take you miles ahead versus just reading the report. 100% absolutely. I would say just reading the RAS report and then reading the scan and trying to correlate it, you're not going to get as thorough of a systematic way of approaching reading various scans. Ideally, what you want to do is sit down with someone who's higher up, some senior resident or attending, to then walk you through the systematic way they go through it. Okay, first I scroll through and I look for this, then I do that. If you are looking just at the RAS report, the RAS reading, and then going to the image yourself, you're going to have a very fragmented way, and having a more structured approach, I find very helpful. You see something very similar with reading EKGs. You want to have a systematic way of, okay, first let me look at the R to R intervals, is it regular rate and rhythm? And then you go through this checklist, and it's much more thorough, and you're less likely to miss things. So I don't disagree with this person's suggestion, but I would just add, try to have someone above you teach you their way of going through images in a more systematic way, because then you're going to plug up all those holes. To become extremely proficient at basic procedures, nothing worse than hearing a team call radiology about a para or LP, lumbar puncture, and asking them if the team has tried, to only hear, lol, no, our attending doesn't feel comfortable, and none of us are signed off. This kind of goes back to the whole not being able to operate. You need to put in the work and time outside of just your immediate duties to get proficient at these things. Seek out those opportunities to learn. Otherwise, you're not going to get good at these things. You have to put in the reps, get exposure, be proactive, ask to get involved the next time there is an opportunity, and then you'll improve. I think sometimes people are being passive, sitting in the background saying, oh, I want this thing to happen to me, it just hasn't happened yet, I'm waiting. You gotta take some ownership, take some agency. Stay hard! Residency is not just about hard work, but also appearances. It is full-blown political system of its own. Dude, when I was in residency, you gotta remember, there were only like 2 other medical YouTubers. I had started Med School Insiders, and then there was Doc Osere and The Strive to Fit. And I don't think there were really any other med influencers or medical YouTubers. So Med School Insiders was anonymous. I used to go by Jay. I didn't even use my real name. Somehow, some residents in my program found out. I think I had started this channel. It was called Life of a Surgeon back then. But now it's just Kevin Jabal MD. And this is when I did finally show my face. And someone at my program had found out about it a few months after I started the channel, and it wasn't the cool people who found out about it, it was the not so cool people who then told the attendings, and there wasn't any large negative direct repercussion. However, there was certainly judgment and scrutiny to make sure that Kevin wasn't doing too much of the side hustle stuff. He needs to focus primarily on being a plastic surgeon because this is a distraction from his main duty to be training here, right? And I remember being extra diligent to make sure I studied a lot, was crushing whatever practice tests we had to be like, you know what? You are not going to ever doubt whether or not I'm being distracted by other things because I'm going to bring my A game. And that's just part of the culture. I think now with social media being far more widespread and so much more common, you're not going to have as much of that negativity, but I still do think the more traditional, more old school, more hardcore specialties, especially surgical specialties, are going to be more judgmental about side hustles than something non-surgical. But yeah, political system of its own, for sure. And it goes way deeper than just that, obviously. All right, my friends, if you have anything to add, leave a comment below. And if not, check out this video right here.